Hello, everyone. Welcome to Tuesday Night Rheumatology. I'm Jack Cush with Rheum Now. Tonight on our webinar, we're going to continue discussing rheumatoid arthritis. Our subject tonight, our panel is focused in on DMARD Choices and Changes. I'm joined by a number of experts in the field, but first I want to recognize the sponsor of this month on RA and the Hard Decisions in RA campaign. That would be BMS. Thank you for your support. So let's begin with our panel introducing themselves. Alan, why don't you go first?
Hi, I'm Alan Matsumoto. I'm a rheumatologist in private practice in Washington, D.C. We're a 25 provider, I guess, physician group outside of Washington, D.C.
Excellent. Artie.
Artie Kavanaugh, rheumatologist, University of California, San Diego. And that's the ocean behind me.
He's really in Brooklyn, folks. Madelaine.
Hi, I'm Madelaine Feldman. I'm a rheumatologist in private practice in New Orleans, and I do lots of advocacy stuff on the side.
Excellent. All right, folks. So what we're going to do is, last week we discussed with Weinblatt, Kremer, Conway, and Wright, methotrexate. And, rheumatologists, amazingly, are like flies to the light bulb on methotrexate. I think we're the same, meaning that we love it. We're all around it. It's like white on rice kind of thing. Oh, I'm already like in HR hell, aren't I? So,
well, Jack, moths to the light bulb. Flies go to you know what, not to the light bulb.
Yeah, I guess I'm like Norm Crosby. I mix up my slogans and whatnot. And look up Norm Crosby, if you will. But I think that we could talk forever about how we use DMARDs, how I use them, how you use them. I'm going to encourage the audience to ask questions along the way. Use the Q&A box. We'll answer your questions throughout the session, and we want to make this as interactive as possible between you, the audience, and the panel. So we're going to begin by going over a survey we did of rheumatologists on the website. The survey invite went out on Sunday night, and everybody answered their survey questions on, let me put this up full screen, thank you, on Monday morning, and with 24 hours, we accrued 231 responses from rheumatologists. This was from around the world, 43 countries, with about 51%, or half the audience that responded, was from the United States. Turns out, in looking at these 6 questions that we asked about DMARD choices and changes, that there really wasn't a lot of difference between international rheumatologists and US rheumatologists. So we'll see some of that. So I'm going to begin with the first question, which was, how do you use steroids? I mean, we had a lot of, I don't know if you've seen, but we have a really nice video on the website where we get the EULAR view on steroids in RA from Robert Landaway, the ACR view from Brian Englund, and the Australian view from Peter Nash. And they really kind of each go over their views, and they are different. But since we're all sort of enamored with steroids, it's not surprising that half of you will use steroids mainly in severe active arthritis. The number who use it first visit all patients is about 20%. That's the orange. But really, severe active arthritis and RA flares accounts for 3/4 of steroid use. And does this bother any of you on the panel? I mean, does this reflect what you do? Do you think there's a fault in some of our thinking on this? Artie, what do you think?
I want to know who the none people are. What is it, 5% or something in that little blue slice?
Yeah.
Because they're lying. They think it's the right answer, and that Jack's going to give them a Rheum Now cup or something because that's the correct answer, but they're lying.
Yeah. But is everybody? You think everybody's really spot on in saying I use them? I use it a lot. I use it in polyarthritis. I mean, your version of severe is not really my version of severe. Maddie, what do you think?
When patients come to me and I can see they're going to have a really bad course, everything hurts, they're depressed, You know, they're really sad that they've got this. They think they're never going to feel better again. Yeah, I put them all in a little bit and tell them that we're going to be taking them off because you know, and maybe this is my sort of woo-woo Zen sort of approach to it. But when people feel better, they get better. And particularly if they're severe, if they have this idea, I can feel better again. I've found when I taper them off, they do just fine, unless, of course, you know, they need a new drug or they need to be increased. But I'm the feel better, get better quicker person.
I think we all do that. I mean, but the problem is between the ACR and EULAR is the ACR believes you're never going to stop it, and EULAR says you're going to stop it, no problem. Alan, what do you think?
Yeah, so I think that's a good point. So we would love to dive deeper into this question. So if you start steroids, how many people have their patients still on steroids after 6 months or a year down the road? And what I noticed in my younger partners versus the older partners is that I think the message is getting through to the younger partners that there are less, they tend to use steroids less. They go to biologics earlier, and they don't even know the meaning of this term bridging therapy that we all grew up with on this panel.
Well, my concern about, and I think that I've seen that in the fellows in the training program, that I think you're right. I think they tend to use less steroids. They also tend to use less non-steroidals. They also almost never use pain meds. Yeah. And I'm thinking, how in the world are they managing these patients? What special sauce do they have that I'm not, you know, slapping on my patients to control them, or are they not paying attention to the minor complaints?
They don't care. Remember, our good friend Alvin Wells always used to say, I got to get the patient feeling better that first visit, or they're going to go next door. I never knew who was next door to Alvin Wells, but it must have been some very, very good rheumatologist, because he says that 100 times. And I get his point, but, I think it's sort of less of the not using non-steroidals, not using a little bit of prednisone. Why would they come back to you?
Yeah. I mean, and when I say use prednisone, I was always taught a little bit goes a long way in rheumatoid arthritis, and I have found that. I'll put patients on 5 milligrams a day for a week and then have them cut it in half. And so they're on 2.5 milligrams, and in 3 months they're off. And I have not found that that's been a big problem. I know prednisone, the P stands for poison in lupus, and probably in rheumatoid too if you use enough of it. So yeah, a little bit goes a long way.
Yeah, and I think what we've heard here from our panel is that most of us in practice are really tuned into the patient and them being happy. When you're a fellow, it's about the job, it's about the clinic and whatever, and there is no next door alternative for many of those patients. So they may not be they're invested in a different way and maybe have different goals. I want to make a comment out to Carter Thorne, who put in a comment that I don't know how to address, Carter, so I don't understand differentiating whatever IS versus oral is. I'm not sure what that is, so if you could explain that, we'll answer it. But let me go on to this, about what influences your choice, because today we're talking about DMARD choices, what you're going to choose first, second, third, what you're going to ratchet back from and whatnot. And again, US and international rooms were pretty much in agreement in that the number one was experience, but safety and comorbidities, almost like there's a deselection process as to I can't use this because of that safety issue or that comorbidity issue. And that's just the reality of management. So, but that accounts for, pretty close to 60% of the patients, with about 20% favoring ACR guidelines, and that's mainly in the US population. And then if I look at just the non-US population, they favor the EULAR guidelines more strongly. So there is a role for guidelines in some of us, but I'm surprised that the guidelines don't take on more of a role in our daily lives. Alan, I actually asked you to lecture on this in the past. Do you think that this is appropriate?
So, I'm actually not surprised that guidelines are not larger in our lives. I really do think that guidelines have limited value or have limited impact in terms of treatment choices and the decisions we make. Guidelines have the tendency that if you agree with the guidelines, you feel vindicated in making your decision, and if you disagree, you find some reason to criticize whoever established the guidelines or the evidence that they're based on. But yes, I think particularly choices for RA, as you go past TNF inhibitors, that safety and comorbidities play a huge role in the choice.
They do for me, and I think for many of us, you know, the interesting thing about the guidelines is that since they're all based on the same evidence and the clinical trials, there's an incredibly level playing field. And I'm going to show you some guideline statements towards the end of this. But at the same time, they do have differences between ACR and EULAR that, you know, when the EULAR came out with its recommendations on steroid use, most US rheumatologists said, oh, that's right up my alley, as opposed to the American ACR guidelines, which were basically say, use methotrexate, don't use steroids. And so again, I think that you're right. When they serve my particular point of view, I'm a guidelines guy.
You know,
Jack, in
I
the
also-
Q&A, they have the question was intra-articular steroids. I think that's a great point. I think what we've been talking about is oral steroids, and intra-articular steroids are a little bit different, although our European colleagues use them as if they were get out of jail free. And they'll do 15 injections and
Right.
you're still getting steroid. I mean, you give 15 times 5, that's still 75 milligrams of prednisone that you're given. You know, you're fooling anybody. So, but usually they're different if you're doing 1 or 2 joints.
There is some bad research from the past saying that not using systemic, but only using intra-articular up to a certain number was associated with less side effects or something like that. But those are not well done studies, and I think that's the story you tell yourself to make you feel better about your use of steroids. But it is compelling nonetheless. I mean, it's part of a lot of the treat to target success, and especially in certain clinical trials, they were pretty liberal about the use of those steroids. I think that happened in the Ron van Vollenhoven study. What's it called? Nordic. What was it called? The early RA study where they allowed intra-articular and systemic steroids. Anyway.
Well, you know, interesting, Jack, that a couple of the health insurance companies' national policies are coming out and limiting now the number of intra-articular injections in general a year that they'll pay for. And, you know, they don't even comment whether it's 4 different joints or 2 different joints. You know, if you're going to inject the same knee 6 times, well, you know, it's really unclear. But I think the important part is that they're going to start limiting the number of injections a year. I think it was 2 or 3. And what if you inject 1 MCP and then the next time you inject a different MCP, is that counted as 2 for the year now? So there's going to be some clamping down on reimbursements for intra-articular injections. So I've only seen it so far coming out in one particular policy, but that's kind of interesting that they're taking that out of our hands.
Do you think it's because they've been seeing the billing of intra-articular injections associated with ultrasound use? So where it goes from, you know, $100 fee to a $900 fee, that's maybe what they're trying to avoid?
I mean, they could always separate it out from ultrasound. I mean, because the other thing that we're seeing is, you know, the 25 modifier, if you inject on the same day as you do a visit, they're not going to pay for both. They want patients to have it done on a separate day. And I think that's to discourage, basically it's to pay less in general. But yeah, so they're going to cut down on the number of injections that they're going to pay for in a year. And there's a number of, and Alan, I don't know if you've come across it in any of your payers or Artie, but you know, this whole 25 modifier on the same day as an E&M.
It's horrible for patient care.
It is.
Just
Our patients are hard enough to
miserable.
get to us. Now we're asking them to come twice as often.
That's exactly right.
It's the 25 modifier as part of the RA high hurdles. And there's a Special Olympics for that. All right, so yes, we're now going to get into what choices people make, looking specifically at people who were on methotrexate and a first TNF inhibitor, and that's the next question that I'm going to advance here. Here we go. So in an RA patient who's on methotrexate and TNF inhibitor, what drug will you add next in active RA? And look, we're really kind of all over the map here. You know, the leading number is a JAK inhibitor, 31%. Next is a second TNF inhibitor, 26%. Wasn't too long ago that the majority of rheumatologists were going with a second TNF inhibitor. So obviously JAKs have made a role, but also the better knowledge about the other MOAs. There's a little bit more in second and third line use, sort of a level playing field, which is what kind of like the guidelines say. And then next on the list looks like it's the IL-6 inhibitor followed by abatacept, and then going back to DMARDs. And again, this is sort of what I would call second line biologic use. Does any of this surprise our panel?
Oh, it's a tough one, Jack, because it's a single answer to an essay question. And I mean, I just saw somebody in the clinic this morning, been on one TNF inhibitor and fantastic for a couple of years, and now says it's not lasting quite as long. What do you do? And he had tolerated it perfectly well. So I gave him the choice, and he said he wanted to try a different another TNF inhibitor. Because he had done so well in the first one and now wasn't doing as well. I have no idea what's going to happen with it, but I think it's all the clinical setting too. So it's a little bit too complicated to ask as a single choice.
Yeah, that's a tremendous fault of this kind of question. But at the same time, the benefit of this kind of question is taking all those if, ands, or buts off the table. What are you going to do? And does any of this pan out? Of course, we never know, because survey questions are your opportunity to look good on paper. Like, I think that this is what the research says. And if Alan Matsumoto was lecturing on this, I'm sure he would be telling me to use, abatacept before rituximab or something like that. In fact, he probably wouldn't. But yeah, I think that I still think it's an interesting exercise, because it takes away, whether a patient wants a PO drug, they like injections, they like the schedule of every other week. They, what their next door neighbor is taking, someone in the waiting room was telling them about this new drug with an X on it or something, and all those things play some kind of role in the decision making that goes on.
I
think a lot of it. Go ahead, Alan.
I was just saying, what's surprising to me is the dominance of JAK inhibitors, considering all the dirt that's been thrown on JAK inhibitors over the last several months with oral surveillance and the thrombosis issue. It's pretty impressive that they still lead the pack.
And a lot of it has to go back to that experience and judgment kind of question, because sometimes you can tell the patient's just not taking it, and so you're going to switch them to an infusion, or they take the a self-injectable when they shouldn't, or they don't take it when they could have, and so that might influence whether you're going to go to a second TNF or not. That there is no cookbook way to handle any individual patient, and I know that sounds kind of trite, but it's true. Every patient has a different personality, has a different, of course, the comorbidities, and I think that's going to influence. But I too am surprised it's over 31% say JAK.
Yeah. So let me complicate this a little more by saying, let's say that whatever your second line choice was after a TNF inhibitor doesn't work, and now you're going third line. What are you going to choose? And again, JAK's still playing a big role. And then it's sort of an equal split, I think, between abatacept and IL-6 inhibitor, but now rituximab appearing as an option in 10%. So this still suffers from the same bias and inaccuracies, but it does say something about JAKs, and Alan's point that in spite of the adversity in the news and in the labeling, and I'll tell you, by the way, that the use of JAK inhibitors in the rest of the world compared to the USA, not much difference. And they too have some guideline, some regulatory constraints put upon them, maybe not quite the same or as bad as the FDA did, but nonetheless, the behavior is still the same.
So the other thing I want to mention is that it's always been fascinating to me, and I guess this reflects I would argue, the conservative nature of rheumatologists, that we really love our TNF inhibitors, right? So these other drugs, ABA and the IL-6 inhibitors, have first-line indications,
Right.
and yet we have never ever moved from TNF inhibitors, even given choices. We've never moved away from TNF inhibitors, and we love these TNF inhibitors so much so that we're trying a second TNF inhibitor over these other products. It's really impressive, because if you look at the data, their first line data is pretty good,
Yeah,
right?
very good.
Yeah.
I think in a
Alan,
patient that you don't want to give methotrexate to, I think an IL-6, it's a good choice.
Alan, what do you find in your youngins? Because anybody with enough gray hair, the TNFs will always have a magical place.
Right.
They delivered us from the land of gold and penicillamine. So of course they're going to have a warm, fuzzy spot in our hearts. But for the youngins who don't have that, in training, it's hard because we don't allow them to have their own opinions as much. But when they get out, are you finding that there's not what do you mean the TNFs brought us from the desert?
I think just because of the timing of the approval of these drugs, and the way these drugs were marketed, that they really never recovered from being second place in the first line, or even arguably the second line armamentarium. And it's a little puzzling to me, actually, and you wonder about the effect of marketing on all of our choices that have just basically kind of reinforced this warm and fuzzy, if you want to call it, a TNF love affair that we all have.
And I know we're not bringing up payers in this particular one, but it's only been the last maybe 4 years where you didn't have to fail 2 TNFs sometimes before you could get to
Right.
another mechanism of action. So it became ingrained in, even if you were young, that you had to fail 2 TNFs before you could get to a different MOA. And I think that has a certain component in terms of that rut that we've been in. We just keep going along that same path of least resistance.
And if you recall the recent ACR guidelines, correct me if I'm wrong, Artie, that they do say that they encourage a different mechanism of action after the first failure. Isn't that right?
I think that's right.
Yeah.
So I want to ask the audience, our panel, do any of you consider these folks who are not responding to your best therapies, whether it's a first line, second line, or third line biologic, do you consider non-adherence as a factor? And does that color what your next choice might be? So let's say you used 1 or 2 injectables, will you go to an oral agent with the hope that, or conversely, an agent that you supervise, like we're going to infuse it in our infusion center, as opposed to let you, freewheel it at home? Does anybody do that?
Well, compliance is the most important thing of all. I mean, there's no drug less effective than the one that you're not taking. And I don't know that mechanism or frequency matters, or cost. I think it's the individual. And that's why I ask people several times, tell me again, when do what day you take your shot? And like, yeah, doc, well, I didn't really take it last month. And
The my cousin Vinny approach to cross-examination.
yeah.
It could work. There's a question from Dr. C. Harriman about what about the use of either PRISM testing, or I'll throw in, for that matter, Vectra assays in making some of these choices. I'll start by saying I've never ordered them. I never will. Why don't you tell me how you use it? Maddie, how about you?
Well, it's gotten the Medicare sort of imprimatur now. So in those states where they've passed mandatory payment for paying for biomarkers, they've now reached one of the hurdles so that it is. I'm impressed with the RA Prism. I get more and more impressed with it. There's many reasons why I haven't ordered it more than a very few, and I think part of it has to do with workflow, and part of it has to do with being unsure if it's going to be paid for. It's always nice to have more of a response test as opposed to a non-response test, but non-response test is, I don't know, Alan, what do you guys think of it?
Yeah, so I agree. This is really a very novel biomarker, and again, this harkens back to this love affair of the TNF inhibitor, right? So it's not as if the PRISM test tells you that you'll get no response to a TNF inhibitor. There will be a percentage that will respond to a TNF inhibitor. It's just that the difference between the test showing you that it will respond and the so-called non-responders is obviously much greater if the test tells you that you are going to respond or not respond to a TNF inhibitor. So I think we're still all afraid a little bit that we would throw away a good class of drugs based upon a test, that there'd be a certain percentage of folks or a large percentage of folks that will still respond, even though the test tells us that they won't respond.
I mean, I could see if they haven't responded and you were thinking of maybe using a second TNF, maybe then might be a time to use it, and it kind of convinces you to move over to a different MOA. It has been used to step over, tiering and step therapy with payers. So many of them are paying attention to it.
Artie, what do you think?
Well, the difficulty with biomarkers has always been the strength of the association and the percent of the population that it applies to. And here it's kind of a negative test, but it still doesn't, to me, it's not so strong to say you really shouldn't prescribe a TNF inhibitor. It's more like rheumatoid factor for rituximab use. There's reproducible data that overall the levels of response are less among people who are rheumatoid factor negative. But for an individual person in front of you, the effect size of it doesn't really sway me enough to say I shouldn't try it. Plus, I'm still forced to use the TNF inhibitors first, and with the data as I see them now, it'd be hard for me to push back against that. You try a TNF inhibitor for 12 weeks. If there's absolutely no response, you're done, and you're done, and you go into a different mechanism of action for sure. Whereas these tests, you send it out, you get it back. Who pays for it? The patient's really mad at you because they got a bill. Your staff takes time doing that. And then you still have to treat, you still don't know if they're going to respond or not. So biomarkers are a very, very high bar, and I don't know that this meets it.
Right.
And then there's the CCP and, the abatacept. So that's another thing that you can use.
Yeah, and the efficiency, though, of CCP and rheumatoid factor is that they're cheap. And if they have even, some suggestion of benefit, I pay attention more to that than, a test like MBDA or PRISM, which is largely developed on a known data set where the known outcomes are. It wasn't a prospective study. It wasn't the right design to build a biomarker. It's all, as Artie has said, and others have said, it's predicting the past, by looking at cohorts. And so that's why I don't use it. Alan, you're going to say something.
Yeah, I think the problem with the way PRISM is right now, and I think they would argue that the data may change as they move forward, but it tells you that you won't respond to a TNF inhibitor, but it doesn't tell you that you're going to respond to the next agent that you choose, right? So, and that's a big part of the equation is that if you say you're not going to respond to something, then are you going to respond to the next drug that comes on? And what's the percentage of that?
I want to remind the audience to please put your questions in the Q&A box, and we'd be happy to get to them. We're lucky to have Madelaine Feldman on this call because she's done a lot of great work in informing us about our next choices and dealing with insurance companies. Maddie, the biggest complaint is by rheumatologists that the decision's taken out of my hands, that whether it's a going to be a biosimilar or the next drug that, managed care is driving the bus on this, taking away my autonomy and control over the situation. First off, what's your advice to the rheumatologist dealing with that?
Well, that's absolutely the case, and which is why we spend so much time trying to get, utilization management reforms passed in legislation. And I think one of the things that really has worked, if people are aware of it, and you know for a fact that patients taking this drug, it's not going to work, or they've taken it before, is utilizing, the legislation that's been passed in your state. The unfortunate part is most people don't know about it because it's real, and the ramifications of exclusions of certain drugs. I mean, we've all found in a number of policies that have come out this year, an entire class of drug gets excluded from even being able to use. So, and that's where our guidelines actually kind of let us down. If you look at the ACR guidelines, they say you can use this or this or this or this or that. And so basically what payers say to us is that, well, even your guidelines say we can pick anything we want, so we pick these drugs, taking away that whole experience and judgment from the equation. And there's been some fairly egregious step therapies and choices, and what is the lowest net cost drug when you have a $10,000 a month drug being chosen over a $300 generic. Why is that? Our patients bear the brunt of that cost. So I think all of that comes into play, and it's unfortunate that, the first question we have to ask a patient when we're trying to make a decision is, what's your insurance? And that's not good. Or it takes you 18 months to get the patient stable. They've tried different things, and now they're on their second or their third. And then all of a sudden their husband or they switch jobs and they can't use that drug anymore. I mean, that's real life problems that happen with our patients.
Yeah. Before we move on, Artie or Alan, you have a question for Maddie about the Spanish care question? Okay. Let's go on to, it comes up also under the topic of our next question, which is biosimilar. These are the answers from, what happened here? No, this is not biosimilar. So I'm sorry. This is the decreasing therapy and weaning therapy. And the answers were the same for US and worldwide. The first question was, who do you permit patients to decrease their DMARD? That could be a conventional DMARD or a biologic or targeted synthetic. And the answers, as you can see, is that rheumatologists worldwide are pretty permissive in allowing patients to wean. So 54% yes if they're in remission, 31% yes if they're well controlled. That's 85% saying it's okay to wean. And that, there's only, very few say no, which is my answer. And I don't allow them to wean. I mean, I know they're going to, but I don't allow them because I spent my whole career trying to study a disease I can't control. And to believe I have it under control and to make the patient believe that and say, yeah, it's okay to stop 2 out of the 3 drugs that you're on. And that's a roll of the dice that I don't want to take. So anyway, what do you guys think of this sort of?
I wonder who that 15% is besides you, Jack. Because if you tell the patient, I do not permit you to taper your drug, what does the patient hear? The patient hears, don't tell Dr. Cush that I tapered my drug.
It's like our kids.
Exactly. They do it all the time. By the time they ask you if it's okay, they've been doing it for 3 months. So I don't think we just make suggestions to patients. We don't tell them what to do. We kind of suggest what we think it would be best for them to do. So, and the reasons for, I'm still surprised that the reasons for people tapering are all over the board. Sometimes it's money. Sometimes it's if the dose is 10, well, 5 must be safer. Why would 5 not be safer than 10? It's less. And you're always talking about side effects. And if it's a lower drug, it's side. And who takes drugs? Sick people take drugs. If I'm doing great, why do I have to keep taking this drug? I don't want to be a sick people.
So Artie, you say we just make suggestions. Is this, as rheumatologists, are we bad parents? I hope that they follow my advice. Like, don't go to that bar, stay away from that boy or girl.
Raising children is the best way to learn how little control you have in life.
And maybe it is a lesson for how to be effective as a rheumatologist who teaches patients a better path in their quest to control their disease. Alan, what do you think?
I think that's right. I think it's extremely popular for patients to want to taper. And if you sit back and you think about it from a patient's perspective, is that you just gave this person 20 milligrams of methotrexate. They still had very active disease. You told them they couldn't drink alcohol, and suddenly you give them a TNF inhibitor and they feel great, right? What's the natural knee-jerk response? Is, well, hell, I don't need this methotrexate crap. I did great on TNF inhibitor, and plus, if I stop it, I can drink as much as I want. What a great that would just seem to me common sense on the part of a patient, and I applaud you if you could convince a patient otherwise.
You just described the last patient I saw today, so which means this is not an uncommon scenario.
No.
There is, and sort of hearkening back to what we had just talked about, there is and I'll name names. Blue Cross Blue Shield of North Carolina had put forth sort of an AI-directed shared savings value-based care program where they would pay the rheumatologist to optimize methotrexate. And I think we all optimize it adequately. I put everybody on sub-Q and, maximize, and if you can tell if they're going to respond or they're not going to respond. But they would pay on average rheumatologists around $1,500 a month for every month they would delay starting a biologic. And it's sort of the same thing for tapering and medication holidays. We came out very strong against this, and they are sort of taking away the tapering and medication holiday, because that really is not in the guidelines. And it's one thing whether we want to decide to follow the guidelines or not based on our clinical judgment, but to be paid not to follow the guidelines, that those optics are bad. And if a bad outcome comes and the patient's relative who's an attorney finds out that the doctor was paid to stop a biologic or to delay a biologic, that's not a very good look at all. So everybody's looking at a way to save money for the system. But I think it's more important to, not have a patient on a drug that they don't need. I don't know if there's any studies out there, and maybe you guys know, that these so-called medication holiday that this particular insurance company was suggesting doesn't always end up well. And in fact, a lot of patients, when they go back, they don't recover, the control of their disease activity.
Well, there certainly are. I mean, those back to you could consider some of these withdrawal trials. I'm going to show you a few. Do prove the fact that people get worse. But the good news is that many of them do recover. And the question is that period under which you're in a flare state, so to speak, does that accrue some damage that that is not easily recovered, or to, for instance, the joint and the cartilage and that sort of thing. So, and then it goes to this next question. When you do wean either a conventional or biologic or targeted synthetic DMARD, what happens to them? The same people who are sort of okay and permissive say, well, most do well and some flare, but very few flare, like 15%. And then there's 5% say, I have no idea, meaning that maybe they're doing telemedicine. I don't know what I don't know means, but I'm always perplexed by that. So that, again, this is part of the permissive thing that is going on.
I think these data, they don't fit with the actual study data that I think you're going to show, where even people who stay on their treatment, about 15% of them flare. People in continuous deep remission stay on treatment, don't taper. 15% of them flare. The disease waxes and wanes. If you stop it completely, that number goes way up. I would say like to 40% or more. And then if you go on a half a dose, it's generally in between. Sometimes you get by perfectly fine with half a dose, but in general, it's in between those two. So
you're talking about this Arctic Rewind study where they kept them on the same dose or half the dose, and those who went on half dose had 25% flares. Those who had stable dose had a 6% flare. That's a little bit different than this other study that you, Artie and I know. Oh, where I left it out. The retro, where you either have no change in arm 1. That's the orange arm. Arm 2 is a 50% reduction, and arm 3 is the blue bar, whereas a reduction followed by discontinuation, looking at flare rates. So as Artie says that, yeah, there's that 15%, even if they're still on drug, that they still get worse, although magnified by attempts to either reduce dose or withdraw drug. Does this kind of data change your prescribing, Alan?
The problem with all these studies is that they don't really model kind of real life patient in front of you. And it would be very interesting to put 50 of us in a room and talk about what our own experience would argue are prognostic factors for tapering, for successful tapering, whether or not it matters, whether or not someone is CCP or rheumatoid factor positive, whether or not their sed rate and CRP need to be absolutely low, the duration of remission. So the longer that they're in remission, arguably you might have a better outcome. Whether or not people use ultrasound or MRI scanning to detect so-called subclinical synovitis before they taper. I mean, all those factors I think need to be considered when people taper, and none of these studies really mirror that kind of thought process when they taper. A lot of these studies, you hit remission for 6 months and then you can taper. Well, obviously there are lots of patients who may not be good candidates to taper.
Yeah, this retro was 12 months, and I think the same with Arctic Rewind was also 12 months. But you're right. There's a lot of other variables that are not taken into account here that do dictate the choices that you make, and I think that this data really are viewed by some as saying, "Gee, don't do it," and viewed by others as saying,
Right.
"Okay to me."
It's fine to do.
Right.
I mean, I think one of these was used by that particular payer, and they were in connection with a machine learning technology as well, and they were going to use the data, I think, to put an initially voluntary program into a mandatory program. The problem is if you incentivize someone, a rheumatologist, even if we'd like to think that we wouldn't change our mind being paid $1,600 a month, I think it's going to be bad data going in. And exactly what Alan was saying there, we'd like to, it'd be great to do population health. It's really nice. It makes things easy. You get, the biggest bang for your buck. But then you forget about those individual patients that don't fit into it. And I think in our field in particular, we have a lot of people that don't fit into the population kind of thing and the approach. And so that's why it's really tricky, particularly if you're going to try to introduce an AI algorithm with data that goes in without all of those nuances built in. And I think that's going to be difficult.
So again, I want to go on this issue of incentivizing rheumatologists to maximize methotrexate. This audience last week heard from Michael Weinblatt about that Jim Odell study that showed that people that went on to biologics did so, 30% of them went on without maximizing or escalating methotrexate. So Artie, do you think that this incentivized thing helps correct what is probably wrong behavior? Is that the greater good here, or is it still evil?
No, I think it's still unethical, because you're incentivizing someone to do something that may not be optimal, as Maddie said, for an individual person based on population statistics for it. I think, certainly there's nothing wrong with considering the, say you should consider optimizing the methotrexate, make that a checkbox. Have you considered, because methotrexate intolerability is not digital, it's a continuum, isn't it? And if you're at 12.5 and you're having to beg the patient to stay on treatment, you're not going to get them to 20 or 25. No way, it's just not happening. So from your experience that whatever it is, they're not going to take it, and all you're going to do is delay the time during which they're uncontrolled, because you're following something arbitrary to say that you didn't maximize their methotrexate.
Well, they also offered triple therapy. They said if you didn't want to optimize methotrexate, and that's, I don't know how many people out there. I've had Medicare patients come in that maybe were already on leflunomide and Plaquenil, and we couldn't get them a biologic, so maybe throw in a little sulfasalazine or even a little bit of methotrexate. But from the get-go, we're gonna start with triple therapy. That's a hard sell.
Yeah, I want to point out John Goldman in Atlanta made a nice comment about patients can certainly wean and then eventually tell me what he's really, I'm going to paraphrase and say that it's really about the relationship. It's about the communication. So you recognize that they may want to change, but that, if you're not beating them up like Dr. Cush does and scaring the pants off them, then, and you have a good relationship, then you can roll with the punches and adjust on the fly and, get them into this state of being controlled or grace, whatever it is that they're seeking. So I like that. I want to just go over the last comment question was, who currently chooses a biosimilar when it's used in RA? And you can see that there's a difference between the US on the right and the rest of the world. Payers make the decision 2/3 of the time in the US. In the rest of the world, it's half the time does the payer or the municipality. And then 40% of the time, it's the rheumatologist making the choice. We have a minority opinion in this. And then it's split between the pharmacist, maybe, and other people. We're now into a new era of biosimilars here with 9 new adalimumab biosimilars joining the 4 infliximab biosimilars. We now have 10 versions of Humira, if you will. And this is going to be an issue. Maddie, do you want to explain, since you're here, of those 9 new biosimilars in adalimumab, I think like 6 of them have this up-down pricing.
Yes.
It's offered at a 5% discount or a 70% discount.
Right. I think, the one that I think is leading is 5% and 55%. I think we have to understand, well, why did we come up with biosimilars to begin with? It wasn't to create the lowest net cost for the middleman. It was to reduce the price of the drug, the actual price of the drug. And yes, when the first, think about it, when the biosimilar, the first Lantus biosimilar came out, they were made by the same company, and they made 2 versions. They made one that cost pretty much the same as the reference product, and then one that was like 80% off. And believe it or not, they were even deemed interchangeable. Both of them were. The only one that made it onto the formulary was the high-priced one. So we know it's pretty obvious now that the higher price makes more money for he who constructs the formulary, because most of the rebates, a lot of them are being reclassified as fees because they don't have to be passed back to the plan sponsor, whether it's an employer or another health plan. So it totally defeats the purpose of why we have biosimilars. Biosimilars come to market supposedly with a low price and no market share. And if you have a low price and no market share, you're not going to get onto a commercial formulary. And we have seen with the lowest priced adalimumab biosimilar, which coming through cost plus drugs is going to be about $600. Even at $600, our patients can't afford that. So someone has to create an insurance for even a biosimilar that's 85% off list price. And if you're not going to get it onto a formulary, I think where those will actually be helpful is if you have the employer-sponsored plans. You know, these large companies that actually pay for the health care. You know, there's one large company that's being told by their consultant not to switch to a biosimilar because rheumatologists won't like it. This is a company that spends $50 million a year on Humira, and their consultant is telling them don't switch to a $600 a month drug. And that's because they're sort of, maybe I'm a bit biased, but they're in cahoots with the pharmacy benefit manager that's been contracted. So I think in those cases, you know, where the employer actually has the choice of which ones to cover, I would encourage them to cover the $600 one, and because that's a lot cheaper than the $7,000 or $8,000 one, even if you get a 50% kickback. And that's the problem. Our payers are all publicly traded for the most part, the big three who make up the formularies, and because they're publicly traded, their fiduciary responsibility is to their shareholders, not to our patients, which is why you have a -5% biosimilar being chosen over a -80%.
Right. I want to be clear that the audience, the 5% discount is so the PBMs and insurance companies and manufacturers can still be in cahoots with the rebate system that's existed in the past. The rebates are not going to be as steep and as great and as profitable, but they're going to be still very profitable. Going with that 70% discount gets you to the $580 a month through Mark Cuban or whoever, but that's still $7,000 a year, which is basically the donut hole for your Medicare patients.
But luckily in 2025, there will be a cap for our Medicare patients for Part D. It'll be $2,000 a year, and it will be smoothed out over the years, so they'll be able to pay about $175 a month towards that. But which, if that really is the case, we may see a little bit of a turnaround in the Part D sponsors, because it will behoove them then to buy cheaper drugs because they're not going to be able to get as big of a rebate. So we may actually see lower price drugs being chosen. But as far as just the regular commercial plans that are fully funded, it's clear, although you may find a couple of inexpensive or at least less expensive biosimilars on, if they can bundle it with another drug that they have that the PBM is making a lot more money on. So you see that oftentimes with, you know, drugs in a completely different disease state that's making a lot of money for that particular PBM, they'll let a slightly lower price drug. It has nothing to do with patient care. And, you know, fortunately, I think rheumatologists are wise enough, and we take our patients individually and we fight for them, but, you know, that takes a lot of time. You know, when you have a prior auth that's 35 pages long, you know, that's the kind of thing we're up against.
You know you're in trouble. All right, so yes. I want to just review with the audience this, where do the guidelines currently stand? And the ACR guidelines for RA treatment in 2015 said that if you were on the right established RA in remission, continue methotrexate, you can wean those other therapies, but they were emphatic saying do not discontinue all drugs. Chance of drug-free remission is incredibly low. The 21 guidelines were a little bit more dancing. They say that the addition of a biologic or target synthetic is recommended over triple therapy in patients who cannot tolerate methotrexate. Continuation of all DMARDs at the current dose is conditionally recommended over a dose reduction of a DMARD. And then they say it's better to, if you're going to do anything, reduce the dose as opposed to discontinue the drug. They say that be a target and maintain therapeutic dose of at least one DMARD if you're going to withdraw therapy. And lastly, gradual discontinuation of methotrexate is recommended over the gradual discontinuation of a biologic or a JAK inhibitor. And that really is based, that latter part, on the results of the SEAM study, the RA SEAM study that Jeff Curtis published. I'll just go and show the EULAR guidelines, where they're basically a lot, when you get to this certain stage, and if someone is improved and doing well in LDA or in sustained remission, they say it's okay to do dose reduction or interval increase is what they recommend. And basically, after glucocorticoids have been discontinued, a patient is and the patient's in sustained remission, dose reduction of a DMARD, either the biologic or target synthetic, and or conventional DMARDs may be considered. In fact, they do recommend stopping the more expensive. They used to recommend stopping the more expensive biologic as opposed to the cheaper biologic, whereas the ACR is kind of the opposite. But do you think that these really inform us in some of the discussions we've had tonight?
No, I think, although like Maddie said, it's interesting because I know in places like in Denmark, they use this to say you should taper, and there's there the money incentive is to the state, but if you're in remission, you need to taper, and I've heard that from some colleagues in Europe. So you get in the situation kind of the opposite of how it was when biologics were new, when rheumatologists would put their finger on the scale to make sure the DAS was greater than 5.1 to be able to get on the TNF inhibitor. Now, I think they're saying, you're not in remission, are you? Because if they're in remission, you have to stop or you have to taper. And if the patient doesn't want to, I certainly wouldn't push them to do it.
All right,
And we spent all these years, driving for remission, wanting remission, just the ACR 2050 aren't enough. We really need remission. And as soon as we've got a decent number, I still don't think enough patients in remission, now the push is let's get rid of those drugs that took us so long to get them into remission.
Speaking of which, tomorrow, Room Now, we publish an article on what the experts do in multi-drug failures, meaning that, and you can define that however you want, not classically refractory RA or difficult to treat RA, but I sent the email request out to many of the leaders in the RA world, and an interesting overview piece from many people on how they manage those who are multi-drug failures. So look at that in tomorrow's Room Now. As we end, I want to thank our panel for a great discussion and great insight. This has been really helpful. Next week on Tuesday Night Rheumatology, we're at the beginning of a new campaign, this time on polymyalgia rheumatica. The title of the campaign is Make Room for PMR. We're going to have a panel discussion next week on the diagnosis and monitoring of PMR. I hope you'll be able to join us for that. Artie, Maddie, Alan, thanks so much.
Thanks very much.
Thank you.
Thank
Good
you.
night, everyone.
Good night.